Welcome, everyone, to today's diagnosis day for polymyositis and overlap myositis. I am so glad with us today. I'm Rachel Bromley and honored to be your host for tonight's session. Unfortunately, our scheduled host for this event, Kimberly Branche, was unable to make it, and we hope she feels better soon. If this is your first time joining us, welcome. We'd love to know where you're tuning in from. Go ahead and drop your city and state in the chat. Just be sure to message everyone using the drop down at the bottom of the chat box. It's a little blue box and it'll say everyone or it'll say hosts and panelists, and you want it to say everyone so we can see how far our community reaches. Let me begin by telling you a little bit about the Myositis Association, or TMA. Founded in 1993, TMA is dedicated to improving the lives of those affected by myositis through research, patient and provider education, support services, and advocacy. Our vision is a world without myositis, and every day we work toward that vision with the strength and spirit of this community. So let's go ahead and get started with some quick housekeeping. I'm going to share my slides. One moment. So you can visit our website for all our resources, event calendar, our Myositis Awareness Month toolkit, and more. Even though the month is almost over, it is still not too late to raise awareness in your community. TMA does not give medical advice, and we ask every speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel around mid-month in June. Please put any questions you have in the Q&A box in the toolbar at the bottom of your screen. If you put any questions in the chat box, they may be missed. Applicable questions submitted when you registered are being entered into the Q&A by TMA staff, so no need to submit again. We will do our best to answer both pre-submitted and live questions, and we will get to as many of them as we can. Questions that do not pertain specifically to this webinar may be answered in future programming. We have a call to action for you for this Myositis Awareness Month. Please ask your representative to co-sponsor House Resolution 277, and Linda will put that in the chat, that link. And of course, I would be remiss if I didn't have a personal appeal for donations during this month. We are getting close to our fundraising amount, at least I hope so. And anything you can give, big or small, is appreciated. So thank you so much for that. All right, well, we are going to go ahead and get into the meat of this Q&A. I am so excited to introduce our expert for this session. These Ask the Expert sessions are some of the most impactful programs we offer at TMA. They give you direct access to some of the world's leading experts in myositis care and research, and today is no exception. So please take advantage, submit your questions using the Q&A box. Engage respectfully in the chat and feel free to take notes and share what you learn with your healthcare team, friends, and family. Now I'm thrilled to introduce our expert for this evening, Dr. Chet Oddis. Dr. Oddis is a professor of medicine and director of the University of Pittsburgh Myositis Center. He supervises a longitudinal myositis registry of over 2,000 patients, and he was the principal investigator on the rituximab in myositis trial, the first multi-center clinical trial in myositis funded by the NIH. He also co-authored the consensus guidelines for the conduct of clinical trials in myositis alongside several esteemed colleagues. We are truly honored to have him with us tonight. Thank you so much for being here. Let me add spotlight. Welcome.
Well, you can hear me okay still? Loud and clear?
Loud and clear.
Well, it's my pleasure to do this. I was around at the beginning of TMA, that dates me for sure. But it's been a long journey for me with myositis, and it's been a great career. I've been able to meet tons of patients from around the country and around the world, and lectured in a lot of places, and it's been my focus of interest for actually since probably the late 1980s.
Wow, how did you fall into this?
Yeah, it was during my training, and it's interesting. I had some colleagues, and one person was interested in scleroderma, another person was interested in lupus. And I go into the division chief and I say, yeah, I kind of want to do academics. He goes, oh, why don't you do myositis? I said, okay, I'll do myositis. So that was it. That was probably in 1985. And
that's amazing.
That's a long time. And I started slow. I didn't have any funding, didn't have any colleagues, didn't have the support like people at the NIH and other universities, but it's been a great run through the years. And like I said, I was there from the beginning of TMA, but actually when it was called the Inclusion Body Myositis Association. And so I've lectured at TMA meetings. Now I let all the other younger people lecture, but it's been a great ride. So it's my pleasure to answer any questions that I can help with.
What have you noticed as trends changing in those 30 years?
Yeah, it's been interesting, Rachel, because in the very beginning we didn't have many medications. Okay, so I can look at it. I can look at things from a diagnostic and a classification perspective, and I can look at the other bucket of treatment. And we've learned so much through the years in subsetting patients. With autoantibody testing, a big part of my career has been looking at autoantibodies that a lot of people know about, I'm sure, on this call. And by being able to clinically subset patients by autoantibody, and then having these new medications available, it's been an explosion of treatment over the past 20 years. It really started with a drug called Enbrel for myositis, or for rheumatoid arthritis, around 2000. And over the past 25 years, I had to go to the NIH to get the funding for the rituximab trial. Now all of these companies are coming to us and wanting to try their drug, for dermatomyositis or the antisynthetase syndrome or other forms of myositis. So that has been, the most impactful, really revolutionary change over the past 25 years, Rachel, has been drugs availability and understanding the disease better, and more investigators that are interested in myositis. It was lonely. It was lonely. I figured nobody liked me, in the beginning. But now we've got all these people that are, young investigators, which is good.
That is good. We have about a dozen questions in the Q&A so far, so I'm going to get started. I would like to let people know that if your question is very personal to your particular situation, we may not be able to answer it. And I'd also want to say it is a trend that folks in our audience will wait until I'm saying the closing remarks and then put their question in. So please don't do that today. Please get your question in as soon as you can. So, let's see here. Has there been any insight to polymyositis affecting pelvic floor muscles?
Well, I've had that question come to me a couple of times, and I think I don't want to spend too long on one question. And I think the most direct answer to that is that there's not been a lot of investigation in that area. And I don't think that there's a lot of involvement of the pelvic floor muscles. That being said, it's always important to build up. And some of these, I looked at some of the questions that came in early, actually ahead of time. It's always important to build up your core strength. And by building up your core strength, that can actually improve the pelvic floor. But we don't have the degree of pelvic floor involvement that a lot of other diseases that involve muscles really struggle with. So I don't think that's a big issue, to be honest with you.
Thank you. And I was remiss. I meant to start off the questioning with the I don't know what exactly to call it, but I do know that sometimes there are some clinicians that feel polymyositis is a diagnosis and others that don't. And I was wondering if you might explain that.
Oh my gosh. Okay, well, that'll take 45 minutes. No, I actually just put together a bunch of slides, and I do have a bias. And my bias is that the classification today should really fall under four general rubric, okay? Four general classifications. Certainly, dermatomyositis is an entity. Secondly, a subset called necrotizing myopathy is another entity. Number three is the antisynthetase syndrome that has characteristic group of clinical features, but they also have an antibody, one of the ones that I mentioned earlier. So that's number three. Number four is inclusion body myositis. And I can tell you that, you mentioned that I conducted the RIM study, and we had patients with, quote, polymyositis. I think that the designation of polymyositis is shrinking. It's definitely shrinking. And the reason is that as we have come to characterize patients better, whether it's by antibody or by rash or by other features, that subset is shrinking. For example, 20 years ago, I called necrotizing myositis. And have you heard that term, Rachel? Necrotizing?
Yeah,
okay.
absolutely.
I called NM, we all called it polymyositis. But now it's called NM, necrotizing myositis, because we have two antibodies that characterize it. One is anti-SRP and one is anti-HNGCR, one associated with statin use. So that subset of polymyositis was that necrotizing myopathy was pulled out of that subset, and that shrunk it. And then there are other antibodies that have been developed or discovered, I should say, that also pulls away from polymyositis. So in my opinion, you have to be very careful when you call somebody polymyositis, because there are also many mimics of polymyositis, such as atypical forms of muscular dystrophy, or even thyroid disease, or other entities that can be classified as polymyositis and meet the criteria, but really are not autoimmune in nature. So it's a long-winded answer, but I think it's a very important point. I'm actually glad you asked that, because I kind of wanted to talk about that, but I thought it might be too complicated for this group. But I don't think
Well, the thing is that people have the diagnosis. They're out in the community receiving them from physicians, and then they come to our our conference, and they might run into someone that is in the other camp that it should not be diagnosed as that anymore. And if I were a patient, that would be very scary for me. That would be so unsettling, to get a diagnosis that maybe brought me relief and then find out that there's, this controversy. So we'd like to just bring it out in the open and talk about it and, get people's experts' opinions on that.
But let me make one other comment on that, though, Rachel.
Yeah.
If somebody has that diagnosis, it's likely that they have an autoimmune form of myositis. I'm just saying that we have understood that entity so much better through the years that it's shrinking. But there's still patients that have polymyositis, and they have, and they perfectly fit into what we call the myositis spectrum. It's just that we've learned more through the years so that we can kind of characterize a lot of those patients a lot better with other diagnostic testing. But by no means am I saying if somebody told you that you had polymyositis, they don't know what they're talking about, or you should be questioning that diagnosis. That is absolutely not the case, because we
So
really.
if they were diagnosed a long time ago,
Yeah,
you think they're just fine to stay as is? They shouldn't.
absolutely. Absolutely.
They shouldn't seek.
Look, I never rubber stamp. If I get a lot of referrals, okay, either other good doctors that see patients, and when they come to me, I look at them with a fresh set of eyes, and I don't say, okay, you got polymyositis, or you got dermatomyositis, or you got this. I look at it myself. I look at the whole picture, and then I either agree with it, or if I disagree with it, I give my reasons. So, but they're probably most of the patients that have polymyositis are appropriately characterized.
My other question is about overlap myositis.
Right.
How would you define overlap
Yeah.
myositis?
Yeah, that question actually, you sent me some things early on, and I thought about that a little bit. And my point with that would be, in order to call somebody an overlap myositis, let's say they have an overlap with scleroderma, okay?
Okay.
Well, if it's an overlap, there can be many different overlaps. You may overlap with scleroderma. You may overlap with rheumatoid arthritis. You may overlap with lupus. You may overlap with Sjogren disease. And the simple and succinct answer to your question would be, they really have to meet criteria that are established for the other disease. In other words, if it's scleroderma and myositis, well, they have to really meet the classification criteria for scleroderma. Or they might have one of those autoantibody markers that goes along with an overlap syndrome. So I think the point about overlap is that when you say somebody has overlap, you want to say it's a true overlap with another autoimmune or connective tissue disease, they really should have features of that other disease as well.
Well, our next question is connected to that. This person was originally diagnosed with SLE in 2010. In 2023, they were told it's not SLE, it's dermatomyositis.
Right.
And so the diagnosis changed. What
Right.
criteria would be required for an overlap diagnosis? And how would I know if I have an overlap versus one or the other?
Yep, I saw that question ahead of time, and I thought about that a little bit as well. So my guess is that, 15 years ago in 2010, they probably had some clinical features of both diseases. Okay, I suspect that they had a rash, and I suspect that then when they went back for clarification in 2023, they probably, in my estimation, likely had more characteristic skin features of dermatomyositis. And I wouldn't say that the disease changed. I think maybe it's just that we become better aware, either by autoantibody testing or even classic features of a rash, to be able to put another patient in a diagnostic category that makes more sense. And it's not that they had a bad doctor in 2010 or some goofy doctor in 2023 that told them something different. It's sometimes the more data that we have available to review, or the more astute we become regarding particular cutaneous manifestations or skin features, we're able to classify patients a little bit better. So I bet the diagnosis of DM in 23 was really made on the basis of maybe some skin features, or maybe some antibody testing, And I'd be happy to, to clarify that further if the person has anything else that they can add to that. But I don't think that's that unusual. We've seen clarification. I wouldn't say the wrong diagnosis, but clarification of diagnoses through the years.
The question is it possible to build muscle back with polymyositis? Can I still do weight training for exercise with PM?
I read that question as well. That's a very good question and a very important question, and something that has definitely changed over the years. And let me just give you a couple minutes on that, okay? So let's look back to early in my career, maybe the 1990s or so. It used to be when we had a patient diagnosed with polymyositis or dermatomyositis, we would say, well, they better be careful. They better be at rest, and not stress their muscles very much. But that has changed. And the reason that that has changed is that there has been good research on exercise in patients with myositis. And the bottom line is that exercise is anti-inflammatory. So when you exercise your muscles, you're not necessarily stressing them and damaging them to the point where you might injure muscle. The important, and it's actually even goes on early in the disease. Now, if you're really sick and you have very bad myositis and you're very weak and your enzymes are off the wall and you have trouble getting around, then you don't start, you don't go out and run a marathon. You don't go out and run, or you don't start lifting heavy weights. But nevertheless, we have learned through the years that you indeed exercise in a slowly accelerated fashion, even when you have early disease. And the question also related to building muscle later on. So let's say you get better and you get treated with, steroids or other suppressive drugs, and your myositis improves, then you can even be more aggressive with exercise. And you can, the question, I have it right here. It says, can I build muscle back with PM? The answer to that is yes. The question, can I still weight train for exercise with PM? The answer to that is yes, because you don't want to stress your muscles to the point of pain, but you want to push yourself. Walking, light weights, accelerated to heavier weights later on is perfectly acceptable. And it's a little different than what was taught 25, 30 years ago.
A companion question to that. Can you please explain CK levels and how they relate to exercise?
Yep, that's a good question. We get that a lot. We get that a lot from doctors as well, because it's very interesting. The CK is a blood test, okay? You stick a needle in your arm, you pull it out, and the enzymes they may be elevated. A couple things that I want to make very clear. Number one, if you have that necrotizing myopathy subset, that NM subset, your levels are usually off the wall, okay? They're super high. Mm-hmm. And with treatment, they come down, and that's a good sign, okay? As they come down, oftentimes that indicates that your muscles are healing, okay? And sometimes they normalize, and sometimes they remain a little elevated. You don't get fixated on if you go from 5,000 down to 500 or 400, that's a good sign, okay? So you don't always have to be fixated if your levels are still a little bit high. And that's with necrotizing myopathy. The interesting thing is some of the worst dermatomyositis patients that I have seen through the years, their enzyme levels aren't that high, and they're not that helpful. So you get a blood test on a patient that you think has active dermatomyositis, and maybe that CPK or that CK is a correct term, CK, is only 300 or 400. And you say, oh, that's not that bad. Well, that's not true. Because you can have a low or a normal, a lower or a normal CK in dermatomyositis and still have significant disease activity. So that's what's tough about the CK, is that it's good as a trend over time. But if you take a one-shot look at the CK, it may be very helpful in NM or necrotizing myopathy because it's really high and you got to jump all over that patient. But you cannot be reassured by a CK that is not that high in a patient with early onset dermatomyositis. You have to do other procedures like maybe an EMG or a muscle biopsy or an MRI to assess the level of inflammation. And you can't always be reassured by a CK that is not that elevated.
This person has PM and scleroderma. They've been on IVIG monthly for the last 4 months. They still have continued muscle weakness and pain. Muscle enzyme labs have not improved. What would you recommend? And I know you don't have their files in front of you, but
Sure.
do you have any general thoughts?
Sure. I mean, the issue with scleroderma in overlap with polymyositis or another form of myositis is that sometimes it can be a little more challenging to treat. Okay, you're right. I don't have the record in front of me, so it's always difficult to know. I mean, IVIG sometimes alone may not be enough. It may be that you have to add another immune suppressive drug. The good thing about IVIG is that it doesn't suppress the immune system very much, like some of the other things like methotrexate and Imuran or Cellcept or other medications. So my point would be sometimes you have to add steroids to the IVIG or methotrexate or another immune suppressive drug to the IVIG. Or the other thing is sometimes you have to be a little bit patient. And after 4 months of IVIG, I would have expected some improvement, but it may be that because of the scleroderma, the concomitant autoimmune disease, that there may be a little bit of a delay in response. So I would tell that patient to be a little bit patient, but to also discuss with their doctor whether another medication needs to be added to the IVIG.
Diagnosed PM 3 years ago, but now doctors talking IBM because of certain symptoms, yet I respond to Cellcept and IVIG. I'm very baffled.
Yeah, that's a tough one. I don't know who that patient is seeing, but they really need to have the clarification regarding whether it is PM or IBM. That is one of the, in fact, I was going to mention that earlier when I talked about PM, because a lot of those patients that were called PM 25, 30 years ago, Rachel, they have IBM.
Mhm.
And as a person that has dealt with this through the years, it's not that hard for me to clinically distinguish PM from IBM because it's a different animal. Okay. With IBM, there's weakness of the fingers, finger flexors. There's asymmetry between one side compared to the other side. There may be what's called a foot drop. There may be muscle atrophy. So, experts in myositis through the years know about the distinction between IBM and PM. And I would strongly encourage I don't know where that patient is being seen, but they really should be seen by a true myositis expert. And I think that they will be able to clarify PM versus IBM.
Do you typically see chondroititis as a symptom? And if so, what do you recommend?
I don't know what,
It's a live question that came in.
hot spell it. I don't know what.
Chondroititis. Chondroititis.
I think that might be the wrong term.
Okay.
I don't, chondritis? I don't know, Rachel. That's not a term that we see. And
Okay.
I'm a rheumatologist too. That's not really a term that we see.
Okay. The weakness has improved, and my rheumatologist believes my polymyositis is controlled through methotrexate and prednisone. I continue to feel increasingly generally ill, and I don't understand why.
Well, by the way, that came through. Costochondritis is I'll go back and then I'll answer this question.
Okay.
It was costochondritis. That actually is inflammation between the ribs. And that's not really a feature that we see commonly in patients with myositis. And I don't care what subset, whether it's dermatomyositis, polymyositis, or other forms. So, and then back to the current question. I'm sorry. Say that again. Repeat the
Weakness has
methotrexate,
improved.
better on methotrexate and prednisone. A
Yes.
doctor thinks they're getting better, but the patient's not particularly encouraged. Is that what I'm hearing?
Yeah, they're still feeling increasingly generally ill.
Well, again, that's a tough one. I mean, methotrexate and prednisone combination is a very good combination for to treat myositis, to treat polymyositis or dermatomyositis. Again, I don't know how long it's been, but you have to realize, excuse me, that there might be a lag phase whenever the numbers look better and the clinician thinks they're better. but there may be a lag phase in the response to therapy. And sometimes the patient mentioned pain. So you always got to remember that there may be other entities that are going on in patients that are treated with myositis. They may have an element of fibromyalgia, because we don't see a tremendous amount of pain in myositis. When I hear patients that have a great amount of pain that exceeds their weakness, it makes me concerned about fibromyalgia. And it also makes me concerned that patients are going to be overtreated for their myositis. Their numbers may look better, their strength may be better, but if they have pain, and we can sometimes are personally frustrated and frustrate our doctors as well. And the doctors tend to push more medication for the myositis when it may be fibromyalgia and not myositis. So you got to be very careful. And that's why, medicine is art and science. It's experience as well as a lot of other things. So, find you have to ask the doctor specific questions, I would say to that patient. Do I have something else? Is this truly all myositis? Could it be fibromyalgia? Could be there's something else going on? Could it be thyroid? Or you always have to keep the door open and the T's crossed and the I's dotted in terms of looking for other possibilities.
That ties in with this next question, because they're experiencing their doctor eternally saying it's fibromyalgia and not PM or DM, when this person was originally diagnosed with DM at age 10. Are they so similar?
Yeah, that's a very big question, a very important question, and a very tough question. Because what happens, like I just said, is whenever you're diagnosed, and maybe you have a very legitimate diagnosis of dermatomyositis or juvenile myositis or polymyositis, and it was pretty well established, but later on in life, maybe that disease comes under control and there's a different emerging pattern of symptoms. Maybe it's more pain. And like I said, when pain tends to predominate, and the spectrum of the initial manifestations are different, you got to take a step back. Patient and doctor need to take a step back and make sure, okay, well, you're saying you hurt more, we'll give you more prednisone, we'll give you more methotrexate, we'll give you more IVIG. No. Sometimes you got to take a step back and say, okay, how do you sleep at night? Or do you have a crappy sleep pattern? Do you wake up feeling non-refreshed? Are you fatigued during the day? Do you ache all over? And if there's the answer to those questions becomes yes, then you may be dealing with fibromyalgia, and you don't want to treat fibromyalgia with more steroids and methotrexate and IVIG or whatever. You want to treat it in a different fashion. But it certainly complicates a lot of our patients. It complicates lupus and rheumatoid and myositis and scleroderma. And I've been, whenever I teach our fellows and our trainees, I always tell them to be very careful, to not overtreat patients who really come in with complaints of pain and the symptoms aren't consistent with a flare of myositis.
Speaking of pain, please talk about some of the solutions for moderate muscle pain, 2 to 4 pain level. I stopped prednisone recently and went from no pain to pain that is noticeable. Also, please offer an opinion as to whether or not patients should receive COVID boosts.
Okay, so the first question of stop, you see what happens when you stop prednisone, and if you're on it for a long time, is you do have an element of withdrawal. It's not like, narcotic withdrawal, where you can go, have a lot of systemic symptoms, but there is an entity termed corticosteroid withdrawal. And whenever you've been on prednisone for a while and your body is, and your prednisone is tapered and stopped, your body has a reaction to that. And it's called the corticosteroid withdrawal syndrome. For years, I lectured to the medical students here at Pitt on steroids, and that is a real entity. So usually what happens with that is that you have to taper prednisone very slowly, and you have to realize that when it is eventually stopped, those symptoms of pain will improve, but it may take time. It sometimes takes weeks or months or longer before that pain is gone. But I would add one other thing, and that is, if there is ongoing pain, like I said, always remember there may be another cause for the pain, such as fibromyalgia, and that's treated in a completely different way. It may be that you can get better with gabapentin or Neurontin or Cymbalta or some other type of medication that'll help your pain without requiring steroids or other immune suppressive drugs.
And the question about whether or not patients should receive COVID boosts.
Oh, yes. Yeah. I mean, geez, that's, I can't say that I push it very much, to be honest with you. I think if you're significantly immunosuppressed, it may not be a bad idea to receive a COVID booster, but most patients probably don't really need it. Again, that's personal opinion too. Not, there isn't a lot of data to back that up. Because I can tell you what, a lot of patients got COVID boosters, and they may have had more frequent COVID. It may have been mitigated in terms of the severity, but I don't think it prevents COVID. It might decrease the symptoms when you get it.
Please share your thoughts on use of JAK inhibitors separately or in combination with IVIG and or mycophenolate in patients with mixed connective tissue disease overlap syndromes, and whether you have observed better success with certain JAKs over others.
I like the JAK inhibitors. I think, we're studying, we're involved in the clinical trial, and I can't give you all the data, and all the data isn't out, but I have looked at JAK inhibitors in clinical trials. And I think that, for example, there's some anecdotal data that JAK inhibitors help lung disease in patients that have MDA5, which is an antibody marker of lung disease. I think JAK inhibitors are really good for arthritis. And I actually was one of the authors on the first case series looking at JAK inhibitors in patients with dermatomyositis. And we found that Xeljanz, which is tofacitinib, actually did improve the skin rash of dermatomyositis, some of the muscle symptoms, and also the joint symptoms. So I think it's a very good drug. And I think there's going to be more data emerging. And then the last part of that question was, are certain JAK inhibitors better than others? And, we've probably got a little bit more experience with Rinvoq that is all over TV. It has multiple indications. It has rheumatoid arthritis. It has spondyloarthritis. It has psoriatic arthritis. It has ankylosing spondylitis. It has inflammatory bowel disease. So Rinvoq is an excellent drug, and it really does improve the symptoms of myositis, but it's just not as published extensively as it is in rheumatoid arthritis.
We've been asked for an explanation of what a JAK inhibitor is.
Yeah, JAK inhibitors. Okay. That means JAK means Janus kinase. It's a receptor. Okay. But the bottom line to think about a JAK inhibitor is that it inhibits whenever there's the JAK pathway in a body, it's an inflammatory pathway. Okay. That means whenever the JAK system or the JAK receptor is activated, it's inflammatory. And one of the inflammation markers that it creates or leads to is called interferon. And that's an inflammatory marker. So what the JAK inhibitor does is that it inhibits the JAK pathway. And there's a lot of different receptors. There's JAK1, JAK2. Forget about all the receptors. The bottom line is that when you block the JAK pathway, it acts in an anti-inflammatory fashion. And the specific marker that is blocked is called interferon, which is a potent inflammation marker. I hope that makes sense.
Please share your thoughts on commonality of PIs as comorbidities with the PM and or MCTD overlaps, and whether the PM and or MCTD overlap patient should be screened for PI as soon as their autoimmune condition is diagnosed.
What do they mean by PI, though?
I don't know. I asked because I was hopeful. They can put it in the chat if they want to explain what they mean by PI. And while we wait for them to do that, can you speak to the Jo-1
primary immunodeficiency? Let's stop right there. Yeah.
Okay.
So the question is, what does primary immunodeficiency have? What What is that?
Okay.
Repeat that question.
Please share your thoughts on commonality of primary immunodeficiencies as comorbidities with PM and or the MCTD overlaps, and whether these patients should be screened for the PI as soon as their autoimmune condition is diagnosed.
I don't necessarily think, I mean, we oftentimes will look, primary PI means primary immunodeficiency, and there are different forms of primary immunodeficiency. There's something called common variable immunodeficiency. I think that if there is I don't think everybody needs to be screened for immunodeficiency once they are diagnosed with PM or MCTD or overlap or some other myositis subset. I think that comes into play if they have an increased frequency of infection in association with either their disease or perhaps with the treatment of their disease. But the short answer to that is no, I do not think that everybody needs to be screened for primary immunodeficiency if they have a concomitant autoimmune disease.
Any tips for how to have a doctor begin to look at myositis as a diagnosis and what to look at as opposed to being told to just do more exercise or that it's very rare, etc.?
Yeah, well, I mean, what you're talking about is, it's myositis awareness. That's what that really relates to, doesn't it? It relates to myositis awareness in the primary care community, and it relates to myositis awareness even among some rheumatologists who don't see a lot of myositis. Okay, so the only way that I would answer that is really patient education and doctor education, and I think we do a better job of that these days. In terms of diagnosing myositis, because somebody say, well, why is it increasing in frequency? Well, it may not be increasing in frequency. It may be indeed that the disease is better recognized. And I think that's part of TMA through the years, the education that they've provided for patients and doctors. So I think the answer to that is simply that, we do a better job of identifying disease these days than we did before.
Yes, TMA has a booth every year at the
Yep.
American College of
ACR, and I always visit it. Yeah, I hopefully when they're little chocolates and stuff like that, I go there 3 or 4 times.
Well, last year I had blow pops and Hubble Bubble or whatever that Hubba Bubba bubble gum. No chocolate, but I'll bring it next year for you.
There you go.
Can you speak to the Jo-1 antibody?
Yeah, I've been interested in Jo-1 since, well, my entire career, because right around whenever I became interested in myositis, only a few years earlier, was that antibody identified. It's a fascinating antibody. And again, I could finish up the rest of it talking about that, but I'll just give you some highlights. The Jo-1 antibody is a marker. It's the most common autoantibody in patients with myositis. It can occur in PM, it can occur in DM, and of course, it is the anti-synthetase syndrome, because Jo-1 is an anti-synthetase antibody. I'm not going to get into I can bore you to tears, but the antibody targets what's called a synthetase. And really, Jo-1 is the most common of the anti-synthetase antibodies. And it's interesting because Jo-1 has, wow, it's just a fascinating antibody. Patients can present with, it looks like rheumatoid arthritis. And they may look like they have RA. They may have bad joint pain. And through the years, you'll see that this patient has arthritis that looks like RA, but then they may develop lung disease, or then they may develop cracking of their fingers, such as occurs with what are called mechanics hands, or then maybe they develop muscle weakness. So the Jo-1 actually is part of the anti-synthetase syndrome. And there's actually 6 features: lung disease, muscle disease, joint disease, cracking of the fingers, and even fever can occur. So a lot of these things may occur all at the same time, and the doctor checks a Jo-1 and it's positive, and boom, there's your diagnosis. But it may sneak up on you. You may have the joint pain, and then later you get the muscle, and then later you get the lung. And again, the most common marker is the Jo-1, and it's a challenge to treat. Oftentimes you're treating the joint pain. That's where the JAK inhibitor, might come in, where you're treating joint pain and muscle. Or you may actually be using medications to treat rheumatoid arthritis because you may be joint dominant JO1. And that's what I call patients that have bad arthritis related to JO1. I'll call them joint dominant. Or sometimes it's lung disease that can kill a patient with JO1. So we have to treat that differently. So that you gotta have your antennae up whenever you're treating a JO1 patients, because it can be a lot of different manifestations and it can be tough to treat.
Our next question actually is about lung disease. This person's CK is normal, but their ILD, interstitial lung disease, is still progressing slowly. They now have pulmonary hypertension. Is there anything they can do on the myositis side to help with the lung disease?
Well, there's nothing that you can do on the myositis. In other words, you can't treat muscle weakness, because if it's lung disease, it's lung dominant. Now, I just said joint dominant. Well, JO1 or one of the anti-synthetase or one of those antibodies, it'll be lung dominant disease, and you have to focus on the lung. And we're doing a lot better in treating lung disease. And one of the features of lung disease, of interstitial lung disease, can be pulmonary hypertension that this patient also has. That's a different problem. That has to be treated by specialists that treat pulmonary hypertension. And oftentimes that's me in collaboration with a lung specialist, or me in collaboration with a cardiologist to treat the pulmonary hypertension. But if the muscle disease is quiescent, I'm not concentrating on treating myositis. I'm concentrating on treating the lung disease. And there are a lot of medications, such as Cellcept, such as rituximab, such as the JAK inhibitors, and other medications now that are being studied to treat the lung disease. But treating the lung disease is a little different than treating the pulmonary hypertension. That's a different set of medications.
Might the CK levels in myositis patients with low body mass be smaller in magnitude than those with high body mass?
Yes. The answer to that is yes, because you may not be able to generate the degree of muscle inflammation because you're of lower muscle mass. So that's why that kind of goes back to what I said earlier. You have to be careful with the CK. The CK can help you, but it may not be the end all in terms of assessing the degree of disease activity.
We have a lot of questions. We're going to be able to get to all of them. One moment. Do you see a lot of Raynaud's with myositis?
Yeah. So part of the anti-synthetase syndrome I forgot to mention is Raynaud disease, Raynaud syndrome. So you actually, that is a very common thread in our patients, is Raynaud disease, particularly in the anti-synthetase syndrome, particularly JO1. And it can sometimes be very bad. Other times it can be simply treated with medications that dilate the blood vessels. So the answer to that is yes, it's very commonly seen. And it's also a symptom that is seen outside of autoimmune disease. And there's, familial examples where it runs in families and things like that.
Can someone with polymyositis be weaned off the medication?
Yes, sure. I mean, I have patients. I mean, one of the questions that came through, Rachel, that looked at ahead of time was about remission. And we have patients that can go into remission. I mean, a lot of times they may continue on very low doses of particular immune suppressive medications. But yes, patients can be weaned off medication if they have polymyositis that goes into remission. It's kind of uncommon, but not to the point where it's like, oh, wow, this patient's in remission. I have a lot of patients in remission. They can be in remission on low doses of medications, and they can be in remission completely off medication. And I have both of those types of patients.
Is there a limit to how long you can be on IVIG?
Yeah, that's a good question. I want to address that because I think that's important. IVIG is a great medication, and we knew it worked for many, many years. And fortunately, Rohit, who's my colleague here at Pitt, did a study. We did a study, and it showed effectiveness in dermato. But just because you're on IVIG doesn't mean you have to stay on that high dose of what's called a gram per kilogram 2 consecutive days every month. And I wean it. I taper it. So they may start off and they do great on 2 doses monthly, but then I may go to 1 dose monthly. And then I may go to one dose every 6 weeks. And then I may go to one dose every 8 weeks. So and this is a very expensive medication. So I'm able to effectively wean patients down on IVIG, which is good for the medical community in general because it's expensive, and it's good for, insurance companies that they don't have to spend exorbitant amounts of money. But yes, you can absolutely be weaned down on IVIG. And I have some patients that are only getting it once every 12 weeks, and that's a heck of a lot better than twice a month.
Do you have any experience treating granulomatous myositis patients?
Very
I'm
rare.
sorry.
No, that's okay.
butchered that.
I got it. Granulomatous myositis is very uncommon. I don't have much experience. Nobody has very much experience with granulomatous myositis. It can occur with sarcoidosis. It can occur in other diseases. It generally does respond to treatment, but it is quite uncommon. The answer is yes. I have minimal experience, and I don't know much that is published on it. I've actually looked at that, and when I've written chapters and things like that. But it does respond fairly well. It's just very uncommon.
Do you have any thoughts on low dose tirzepatide? Could it interact with methotrexate and prednisone?
Tirzepatide?
Tirzepatide.
Well, there's a medication like that treats osteoporosis. I don't know if that's what they mean, but that's not a medication that we use to treat myositis. I don't want to.
I could go to one of those drug interaction indicators and
Yes.
put their medications in to see if there's any.
They're very good. They're very good to look at too.
Yeah. How often should one have the antibodies test?
Oftentimes it's once. I mean, they may decrease over time. I get that question a lot from doctors. Once I identify Jo-1 antibody, I don't check it every time, or what's called the anti-HMGCR antibody for necrotizing myositis. And research purposes, we've actually published on the change in antibodies over time. But really, once you're identified as Jo-1, you're always Jo-1. And the other thing is you don't shift from Jo-1 to MDA5 and then to something else. You usually one. It's very rare to have more than one of those specific antibodies.
If you have polymyositis, what are your other options when it feels like all meds have been exhausted?
Okay, so the question is, you have polymyositis. They've been through a lot of treatment, and it seems like there's not much left, right?
Yes.
Well, when I hear that, I actually want to make sure that patient does not have inclusion body myositis. We've seen that, and once I always tell our fellows that the fellows that train with me is, if a patient comes in with quote refractory polymyositis, make daggone sure that they don't have inclusion body myositis, okay? Because inclusion body myositis does not respond to treatment. It's very sad. I get very upset. It's no fun to sit across from a patient with IBM and tell them that there is no good treatment available. But that's oftentimes what happens, is that they're misdiagnosed. So you got to make sure that you have the right diagnosis as a first thing. And secondly, it depends on what they call unresponsive, because a patient's sense of unresponsiveness can be a little bit different at times, and they have to discuss that with their doctor.
Have you ever seen mild acute neurogenic atrophy on muscle biopsy in a patient with an inflammatory myopathy? Could this be related to an autoimmune process?
Yeah, so that's a good biopsy. So oftentimes we'll see biopsy reports that says neurogenic atrophy, and that's kind of vague. Neurogenic atrophy is very different from inflammation in the muscle tissue. So if that patient has a biopsy that says neurogenic atrophy, they should ask their doctor, does this mean that I don't have myositis, or is there myositis and neurogenic atrophy? Because neurogenic atrophy is not myositis. And I've seen that in patients on their biopsies, and you have to be careful not to overtreat that.
The diagnostic process for overlap myositis, what does that look like? Is it normally one diagnosis and then there's still symptoms and then later another diagnosis, or is it diagnosed together at once?
Yeah, so that's a tricky thing, because I think when you diagnose somebody with overlap myositis, as I said before, they really should have evidence of the two different diseases. And number two, there are antibody markers that are associated with overlap, such as the anti called U1RNP. If they have U1RNP, then they may have what's called mixed connective tissue disease, which is an overlap syndrome. So when you diagnose an overlap syndrome, you really should have features of two different diseases, and you may even have blood tests, antibody blood tests that reflect an overlap as opposed to a true specific myositis antibody. That's a little hard, Rachel, to explain, but that's the best I can do for you right now.
Thank you. And we're coming close to time. So my final question I would like to ask you is, how do you comfort or any words of hope that you have for people with polymyositis or overlap myositis, with the people that you see in your clinic and also who might be on the call today?
Yeah, I think I think they should have a lot of hope. And the hope comes from the fact, kind of what I said earlier, doctors are better at diagnosing. New rheumatologists are being better trained, and those are the people that they're going to be likely to see. There are more drugs available to treat patients with overlap syndrome. Remember, 25 years ago, for rheumatoid arthritis, 25 years, all we had for rheumatoid arthritis was methotrexate. All you got to do is sit and watch TV, television, and see the explosion of new drugs for rheumatoid arthritis. And those same types of drugs are being studied in myositis right now. I mean, we're involved in probably 3 to 5 clinical trials at Pitt alone, on all the different medications. So I would say to that patient with overlap myositis or polymyositis, hang in there, because more data is being accumulated, more drugs are available, and we're doing a heck of a lot better job of both diagnosis and management.
Thank you. And that is all the time that we have. Thank you so much, Dr. Oddis, for sharing your time and expertise with us tonight. This has been an incredible Ask the Expert for polymyositis and overlap myositis. Thank you to everyone who joined us and contributed thoughtful questions. As we close out Myositis Awareness Month, we want to express our deep appreciation for all the awareness, advocacy, and generosity you've shared with us this May. We're moving toward our fundraising goal, and if you haven't donated yet, now's the perfect time. Every dollar supports research, education, and resources for individuals and families living with this. And if you're in the area, join us tomorrow night for the Sea Potter Classic Community Baseball game in Alexandria, Virginia. We'll be gathering to remember Carolyn Potter, celebrate community, and enjoy a casual summer evening of softball, all to benefit TMA's mission. It's a fun, family-friendly way to support a great cause. And if you're inspired to host a fundraiser of your own of any type, we've had car shows and art shows and golf tournaments. We've got whatever, suits your fancy, tickles your fancy. We are happy to make it happen for you. You can email me at rachel@myositis.org. Thank you again for being part of today's event and for everything you do to strengthen this amazing myositis community. Now we will end this webinar and invite everyone to immediately join us in our cafe chat happening directly after, link in chat. It's a social hour to commiserate with others on your same journey, hosted by TMA volunteer Holly Jones. See you in a few minutes. Bye.
Bye, everyone. Thank you. My pleasure.